Is brought to you by the Georgia Neurosurgical Institute. For over 50 years, rendering neurosurgical care to patients of all social conditions, treating complicated problems involving the brain, spine, spinal cord, and peripheral nerves, endeavoring to encourage quality care, medical research, innovation, and education on a local, national, and international basis.
Good evening. My name is Joe Sam Robinson, and I'm pleased to have with me tonight my confrere and member of the Institute, Dr. Lee Hyer. Welcome, Lee.
Nice to be here again.
And tonight we're going to talk a little bit about the vagaries of memory loss and for our aged population. And you see a lot of those people, do you not?
I do. And vagaries is a good word because I think in the last 5 or so years, Dr. Robinson, things have really changed in the field regarding what we know about the brain, what we can do, and what we can't do.
And so there's a limit to what the redemption that any physician or medical facility can offer to a brain that's really been devastated by different pathological processes, the withering effects of old age, vascular disease, small vessel disease. There are things we cannot redeem.
Right.
But you make an effort to do what you can do, and there are a lot of patients that are under your custody. Is that correct? And tell me about that.
Well, you know, from the 30,000 foot level, cognitive aging has undergone a renaissance. And generally, people ineluctably decline. It's just the part of the species. And as part of that, the brain declines. In fact, it decreases in brain weight, for example, by about 20% between age 60 and age 90. And so as a function of that, and as part of just people getting older, most of us do reasonably okay. Our short-term memories get a little spotty, but we do reasonably okay. But about a third to a half of us, once we get into the older ages of 85 and above, start to really have problems with memory. And at GNI and at Mercer, we've been able to develop some programs to assist with that. And I should say, too, that it was about 10 years ago when I sat in New York City with the head of Rockefeller University, the think tank of what's coming for aging and what's coming for interventions. And the promise was at that time, this is 2000 now, that we would have a vaccine for Alzheimer's disease.
Yes. Rather a inappropriate boast.
My goodness. You know, and here it is 10 years later, and I would say in the last 2 years, everything is up in the air.
Yes.
Everything that was thought to be certain, and the A-beta cascade that goes on with Alzheimer patients and the aging brain, now is unclear and spotty and very confusing. And so, although there are 102 new substances in the pipeline, none of them are approximating what we would consider like a vaccine.
Yes.
And so these are agents that might help here and there, but they're not going to cure, at least not yet.
Yes.
So what I do with the components of the aging brain, you know, the brain gets smaller. The brain.
So how large do you think my brain is right now? Maybe a tennis ball, but no, it is. That's I'll just make a peripheral comment. When I operate on any aged person, I mean, there's obviously just to look at the brain, as I do quite frequently, it's the ravages of age are very obvious.
Yeah.
And there is a substantial, I guess, distance between the skull and the brain in an older person that causes a host of difficulties. But continue.
Yeah.
I just wanted to make that comment about it. Also, it's general. Appearance changes with age too. It tends to be a bit more yellow. The vessels don't quite pulsate with the same vigor they would in a young person. So it's the same the same general aging that we see in our corpus as we walk down the street. We're no longer 21 years old. The same thing in the brain. Well, continue there. Continue.
That's exactly so. Well, the bad news then is that this happens, as you just described it nicely. And we have people in high percentages as we get older and older developing mild cognitive impairment, segueing into dementias of different types. And that's ravaging. The good news is that there's a lot of things that that we can do to help people
Yes.
stave that off, or at
Yes.
least handle it better.
Yes.
And at GNI, we have a couple programs in conjunction with family medicine
Right.
that we've been able to institute over the last year
Yes.
plus.
Yes. Yes.
One of those is we have some computer programs to teach people how to think. And
Oh,
they're
is that
quite
is that oh, is that that seems to be can one start earlier in life than is that
Well, that's a good question, and it's an empirical question. The answer is not in yet, but
Yes.
it appears as if people can start in their 60s when the decline starts to take its toll, let's say.
is the first thing you can't find your keys? Is that
the first thing
as
is
I cannot sometimes.
the
Yeah.
first sign is you begin to like operating on brains.
Yes.
That's
yes.
a
Maybe
real
that's
problem.
the first. That's the problem.
right.
Yes. Yes.
But somewhere's in that ballpark, when people start to have problems, people can be trained in ways that make a difference. So we have two programs specifically. One is this computer program called CogMed, and we now have about 60 people, and the data are showing that people who take this training, and it
Yes.
trains people in memory, and nonverbal working memory. Working memory has become the new gold standard of intelligence. They're no longer measuring IQ in schools, they're measuring working memory. That's the correlate.
Now, can you define what is working memory? That's rather complicated. You're going to give us a quite complicated definition, I think.
I'm going to simplify. Working memory is basically being able to think on your feet, hold information, put it someplace, and bring it back when you need it. Much like a lawyer or
Yes.
a physician in an
Yes.
operating
Yes.
room, trying
Yes.
to figure out what to do with this brain when there are complications.
Yes.
So working memory is basically a kind of executive function for people to be able to handle the situation and do it with some aplomb.
Yes. Yes.
And older folks have that ability. The problem is they're not as facile with it. They're not as fast. They can't always bring the things back that they want to. The
Yes.
hippocampus can't always borrow
Yes.
from other areas.
Now
of
you
the-
mentioned the hippocampus, which I can say means seahorse, but
Yeah.
nice Latin word there.
It is, and it's the soul of, it's the grand central station of the brain.
Yes.
You're listening to me and I'm listening to you, and
Yes.
the data is going into the hippocampus through different
Yes,
processes.
yes.
And then the hippocampus will hold it and store it places when it needs it.
Yes.
So that at the end of this time, maybe I'll remember some of what you said and you remember some of what I said. And the hippocampus is largely doing that.
Yes.
With old folks, that hippocampus starts to shrink.
Yes.
And so it's less efficient. So this one program called CogMed, and there are about 7 of them out
Yes,
there, but
yes,
this is very competitive, is one in which we have people for 5 weeks, 5 times a week, go through this program where they learn to sort of think differently in a nonverbal way. And at the end of the time, they're able to do better. We know that because the scores are better on their post-tests, but also it's transferable to other
Yes,
things in
yes.
their life, and it's reasonably durable. So
Yes.
it's holding on for 6 months at least. That's been the elegant program.
Yes, right.
And the people that we've tested in this, by the way,
Yes.
are people that have memory problems. These are
Yes.
not optimal aging people
Yes,
like
yes.
yourself.
Well, I mean,
So, but
I
so
don't. I didn't
that's
think
good
I was
news.
that old. No.
Yeah.
Maybe I am. Yes.
Yes. So that program is working pretty well. We have another program that we run out, and we now are finishing our 60th patient out at Family Medicine GNI in cooperation with them, where we basically take people who are a little bit lower than the group I was just telling you
Yes,
about for
yes.
CogMed, and we train them in 4 or 5 areas of lifestyle.
Yes.
We have a manualized 6-session program, and we take them as a group. So we take a cohort of about 15, and we train them on memory techniques.
Yes.
And we target working memory.
Yes.
And one of the things I tell these people consistently is that they don't have a problem with memory, they have a problem with attention. That their memory might be okay, it might not be okay, but their attention is pretty poor. They don't concentrate well. And the study that got me involved with this was one that was done a couple years ago, where they took older folks and they sent them out on their week, 127 of them, and they said, for 8 days, we're going to buzz you with a Palm Pilot. And when we buzz you, we want you to tell us what you're doing and whether you're doing it well. Well, they did this. They had 127 people times 8 days, eight times a day over 7 days, a lot of data. And when it was all said and done, they had people who they knew had good working memories and those who had poor working memories. Again, that working memory construct. And those that had good working memories had a major difference from the other group. And the difference was that they were attending, they were paying attention, they were intellectually curious, they were focusing on what they were doing. So we teach these people who have memory complaints and objective markers that are down how to attend. And we rub their faces in it, all 6 sessions. In addition to that, we do things like making sure they're exercising well, making sure that their health habits are pretty good, they have a good physician, a good healthcare team, and we teach them how to relax. Those are the core elements that we also give them a diet, the Mediterranean diet, but that's a secondary issue to the other ones that we really
Now,
try.
are you able to, I think one of the things that often happens with older people, it's been my experience, is they want to stay in their domestic, I guess roost is the way to say it. The thing that I've seen with older people is they dread the most is going to some kind of external care or extended care facility. They want to stay in their home where they have their cat or dog there, and their family relationships are close by, and the accustomed accoutrements of their life are there, and they're very resistant to leaving, and it's a tremendous family dilemma many times. Are you able to, can you do this weightlifting, intellectual weightlifting for the hippocampus? Could that help and preserve people in that situation?
That's also an empirical question to be answered, but the short answer at this moment seems to be that the better lifestyle, the better cognition, the better exercise, and the better ability with diet and having a good healthcare team, that does prevent them going into these longer term facilities. In fact, the government, as you know, but better than anybody, as an expert in this area on healthcare, the government is really making an effort, and it's going to do so over the next decade, to keep people in their homes. That's where people want to be, and that's where they can be. And in fact, there's an old construct in psychiatry called the person-environment fit. You can match an environment with a person, provided you have some creativity to make the environment come to the person and work with them. I've had people in New Jersey at Rutgers and Robert Wood Johnson who had scores where they could just about remember their name.
Yes.
And they were on the 11th floor of this one particular person was on the 11th floor of a high-rise in New Brunswick. And he was an Afro-American gentleman who was 85. And he was brought in by his 2 buddies who had apartments next to him. He had no family.
Yes.
He could live there because they took care of his shopping. He didn't have to cook at all. They took care of his finances. They liked old Joe, and he could handle anything. So that environment met his needs, and we said, fine, stay there. And obviously, other people are all concerned about going into the worst place in the world for anyone who gets older is a nursing home.
Does that make, in general, cognition, does that have a negative impact on cognition? Or
it does. It does. And the number one predictor for bad stuff in hospitals is cognition. The number one predictor for bad stuff in nursing homes is cognition, and it's the chilly wind that comes out of the north that just runs amok with problems. It's consistently bad. In fact, I do some tapes for CMS who run Medicare, and
can you say what CMS is?
That's the official group that runs Medicare, Medicaid in this country, and they've been involved probably for 10 years now doing this with taking over for Medicare, Medicaid, and the reason that I do films for them is because they're interested in creating an environment in nursing homes where the surveyors in the state can go in and look at the nursing home and say, we're not going to give excessive medicaments to these people. We're not going to psychiatrically ruin their CNS. We want them to be happy. We want them to do different things. So we're going to really monitor. We're going to do what we say we were going to do. We're going to monitor their meds. We're going to monitor all the markers that are problematic, like bed sores and those things. But we want these people to be happy. We want them to be up and about. We want them to be functioning. And so my job is to sort of communicate what cognition is in these homes and dementia, what you can do in lieu of the medications, what you can do with depression in lieu of medications, what you can do with anxiety in lieu of medications, and even pain. Those are big issues.
So as long as we're discussing memory, could you bounce the basketball on long-term memory and short-term recall? I mean, is there some difference in that? And I mean, what suffers in the aged brain? I mean, it's often, I think people can can at least tell stories about their elderly grandfather that can remember everything in the fourth grade, what happened, and that seems to be preserved. Any comments about that? How are things imprinted so strongly? Does that stay in the brain? And
those are good questions. And the tests that I give people subserve recall, and there's short-term recall, and then there's what you did in high school recall. And then there are verbal issues and there are nonverbal issues. Typically, when someone gets older, their ability to remember what they did a long time ago seemingly is not impaired. In fact, it is if you really looked at the objective data. But it's not impaired to the extent that it relates to short-term memory. Short-term memory is a problem, and that's where the rubber meets the road. And so I'll sit in front of people and give them different tasks to do, and then I'll ask them what it is I just did.
Yes.
And those with short-term memory problems are not able to reproduce that very well.
Yes.
In fact, some of them won't even remember that I gave them a task to do. Others will sort of puzzle and they'll say, oh, I know you did that, but I don't remember what it was we did.
Yes.
And so the challenge for me is to sort of fit what I can do and what the environment can do so that we can train these people up and increase the synaptogenesis and the neurogenesis and the synaptic density, so these people get some benefit from this. And we now know that we can do that. We don't know how long it's going to last, and we don't know if you're 65 years old, you're on average going to live 18.6 years. You're also on average going to have at least 1.5 years of cognitive decline during that episode, that period. So we want to reduce that to half or less than half to where it's, and we want to make it a loving 1.5 years if it has to be, so that people can really do stuff and feel part of things and not be so afraid of the D word, the dementia word.
Is that a big family unit problem? I mean, are families pretty impacted when their beloved grandmother starts to go down? It really causes a family crisis often, doesn't it?
It does. And that's why the one area that you can make a difference, in addition to the one that I'm talking about, the memory stuff and teaching people to how to handle themselves prior to the point where things are really bad, the one area you can make a difference is with caregivers, and caregivers are the family.
Yes.
And
and generally the females, may I say? So the daughters are going to be. I don't know if anyone's out there listening to this, but I'm sure they would nod their head. When the mother starts to have cognitive impairment, the females, the daughters, are going to be the people that have the traditional assignment of.
So fathers have daughters and raise them well.
Right. So because they'll be the people that will look at it. Sons will be less available.
That's
not always,
true.
but I mean, as a generalization, you would say.
We now know a lot about caregivers, and they really are the unsung heroes, and the numbers are upwards of 20 million caregivers doing different tasks for traumatic brain injury and dementias and every difficulty you can think of. A lot of difficulties that you guys see.
Yes.
But it's now evident that if the caregiver is depressed, if the caregiver is burdened, that they retranslate that in a bifurcated way back to the patient. So they make the patient worse. So, and it's unfair. There's no bad guys here. It's just the way it unfolds. And so taking care of the caregiver is important. It's really critical. If as you and I know, people start to get very impaired and their instrumental activities of daily living start going down to where they're not able to do their own medications, they can't drive anymore, their finances are needed, need some assist from the caregiver. Those are pretty critical things, and how the caregiver responds to that is pretty critical.
Isn't that one of the first things that occurs? I mean, as one faces the ravages of old age and dementia, the numbers, people, their financial issues can often go awry. Finances
is one of two. Usually, one of the questions I always ask older folks: what medications are you taking?
Yes.
And do you manage your meds? And typically when people are having trouble, they don't know their meds, or they don't manage them, or both.
Yes.
But finances are another one. And finances, there are lots of horror stories where they've just let bills lapse, or there's a pile of bills on the desk that they haven't touched for 6 months, and the creditors are calling and all. And that usually is an early warning system marker for the kids. They'll come over and they go, "Dad, I got a call from the bank saying that you didn't pay such and such."
Yes.
And you can see how that would affect everybody and how devastating that would be. And again, that starts the dance. And the dance is, how can the caregiver intrude but not take over?
Yes.
How can they be benignly helpful but not persistently annoying? And that's a gift. It really is.
So there's a lot of grace that's needed in family relationships as the aged parents or grandparent gets into the situation.
Yeah.
Well, what about a sleep-wake cycle? I mean, is that an important issue? I mean, people that don't, I think in old age, the regularity of sleep becomes diminished. Is that correct? Does that play a role in this problem? And any comments about that?
Yeah. Well, two thoughts. One is, leading up to a dementia, poor sleep is a prodrome and soft risk factor. And typically what happens is people who sleep less than 6 hours, it's a question that I ask, 6 hours a night, tend to start to have cognitive problems. And if they're insomniacs, that's a clear risk factor for dementia. So there's the lead up to dementia, and poor sleep is a marker for that. Once one has this dementia thing, sleep really gets erratic, and you find two kinds of sleep problems with people who are dementing. One is hypersleep. They'll sleep 10, 15 hours a day, sometimes due to meds, excessive meds. But that's not a good thing, and that's really a marker for problems, because they're doing nothing and they'll start having poor health problems and et cetera. And the other is just sleep-wake problems, so that you have things called like sundowning, where they'll sort of be inactive during the day or reasonably compliant, and at night they start to act up. And that needs to be taken care of either with reasonable meds or with a monitored day in which they're more active. So sleep is a big issue.
Is one of the, I guess, underdiagnosed problems in older people and people that may have some patina of dementia is sleep apnea.
Oh, yeah.
Is that something that might at least be correct sleep problems and also improve oxygenation to the brain? I think there's more and more attention being directed to this. Do you have comments on that?
Yeah, sleep apnea, as you know, is a problem with hypooxygenation to the brain over time. And if you have somebody who is a sleep apneic for 10, 15 years and they've not been getting oxygen to the brain night after night after night, you can see how that would be a problem leading to dementia, and it becomes a risk factor. Once people reach older age and put on a little weight or are starting into a dementing process, the prevalence of apnea goes up.
Yes.
And the question is what to do at those moments, because if somebody has sleep apnea, let's say at 75 or 80, is a little heavy, and is starting into a dementing process, the question would be, do you really want to start to put them on a CPAP that might be scary to them? And what would you prevent? How much? So there's a question there that needs to have a clinical sort of input. It's a patient and a problem, and how to make that work for people. But it is important because they're going to lose brain power.
Yes. Now, one of the things that often eludes people at different stages in life, and for many people their whole life, is the bluebird of happiness, if I can say that. So a person that's happy, they tend to, their cognitive ability is preserved. Is that correct? So if you can find, one of the things is with an elderly patient or person that has some dementia issues, is just if having a happy environment, something they like to do, not being depressed, that helps a lot, doesn't it?
Oh, it does. And you can see the continuum of someone who has dementia, and the continuum now go out for 30 years, but typically it's between about 8 and 15 years. And as you, in the early stages, optimize positive affect or happiness, it's a little easier to do, but it takes some creativity because people have input. I mean, they can make decisions and they know what's going on. And generally, if people have insight into their situation, they can make a lot of input into that. Once you get beyond a certain point of 10 to 15 years into the process, when you really have trouble with, differentiating between day and night and when is supper and that sort of thing, then you have to get creative with maximizing happiness. The Israelis do a good job and the Swedes do a good job. We don't do a good job because they really make a stimulus preference assessment of what people like and what they normally would do, and make sure that that person has that. It's done nicely, actually, in Israel, and I have colleagues that we just finished a book on that, actually. And it's quite sophisticated and quite humane and quite nicely done. And it's all in creating an environment so that people who are very demented are able not to be noxiously annoying and feel some degree of happiness. But you know, Dr. Robinson, the challenge with getting older is in accommodating.
Oh, really?
I mean, just think about it. You know, I ran the race on Saturday, and my left leg has been hurting ever since. So I have to constantly accommodate. And what happens consistently is people are hit in the nose with something that goes down over time. The word I use has been ineluctable, and it continues to go down. So your challenge is to take it in, assimilate with it, and deal with it, and accommodate, so that you can't play 18 holes of golf, 5 times a week. You have to do it 1 day a week, kind of thing. And that's the real challenge of being happy, of saying I don't have to be that 5-day-a-week golf player. I can be the 1 day, and I'm still going to be a pretty good guy.
Right. Well, I guess if I could quote Erik Erikson, I'm bringing him up slightly, but in really the last stage of life, it's a struggle between despair and integrity. So the idea and I think the family members promoting a sense of integrity about the person's life, I think is a very useful. It's a very useful thing, because the old age, the depression goes along with it, changes in neurotransmitters. And that makes things worse, doesn't it? So if your cognitive ability is going to go down substantially, if you're depressed, there's a change in neurotransmitters, and trying to understand what's happening and respond to it, and preserve one's integrity and sense of integrity, I think is important in old age.
Absolutely, absolutely. And you know, this is just an area that we just don't know enough about. That last year to 2 years of life when people are declining, and we know how that is now. It's not, the compression of morbidity was, you live to 91 and you have a week of badness and you die. But nobody does that. Everybody lives, and then they start having the problems in the last 3 to 5 years of life, and that's the trajectory that we're faced with. And so, how to make people in control, and how to have palliative care meaningful during those last years of life with not excessive cost, and doing it in a way where there's a lot of humanity, those are tough issues, and we don't have the answers to those yet. But you're absolutely right. People need to accommodate with integrity versus despair. The last stages of Erikson was the love, care, and wisdom sections of life, and people wrestle with themselves differently in the last year. I always remember the Einstein quote when he found he was going to die, and he said, "I'll be so curious to see how this works." All of us should be that way, but none of us probably will. Because we really want to. I mean, he wanted to study himself and to see how that decline process was. That's a noble person. Well, it's something that we, if we're lucky, we'll all go through old age. If we're not so lucky, we might not make it that far. I think coming to grips with old age is a big issue. And I think from my point of view as a neurosurgeon, often we see people in the last stages of life, and I think people are getting more reasonable about not being excessively aggressive. I mean, I think there's certainly a time to not be aggressive about maintaining the last ember of life in the intensive care unit. And I really think if people think about it, accepting that would be a good thing. And I don't know anyone that's in a health profession. I think they tend to understand these things. And they don't want to stay on the ventilator for the last 6 months. I think that's a reasonable opinion. I think you're right.
What do you think? I'll give you 30 seconds to say. What do you think the future holds for promoting cognitive ability?
I'm optimistic, really optimistic. The acetylcholinesterase inhibitors that have been out now for 20 years give us a little bit of a boost, not much, and for most, not a boost at all. So we have to do other things, and we're beginning to learn how to do other things. And I think GNI has attached itself to some of the better institutions in the North, Hopkins being one, where we're now looking at what we can do to maximize people. And we get people who really look at themselves and I think make changes meaningfully by just training them up on simple ways and being very human about it.
Well, thank you so much, and it's great to have you here. We'll talk some more about this important issue, and we hope I hope our viewers have been able to learn something tonight. Thank you so much.
This program is brought to you by the Georgia Neurosurgical Institute. For over 50 years, rendering neurosurgical care to patients of all social conditions, treating complicated problems involving the brain, spine, spinal cord, and peripheral nerves, endeavoring to encourage quality care, medical research, innovation, and education on a local, national, and international basis.